Okay. Bismillahirrahmanirrahim. Assalamu alaikum and welcome everyone to this webinar on the WHO World Patient Safety Day 2021 with the theme of maternal and newborn care, which is very relevant to this conversation today. I welcome all of you and especially our speakers from the US and from Pakistan. Professor Dr. Paul Barish, who's here with us. He has been a very close friend of not only myself, but Pakistan as well. He has visited numerous times. He has helped organizations, institutions in the country in developing not only individuals, but organizations and the culture, which I'm sure he will talk about today. Uh, I'm also extremely grateful to Professor Dr. Halima Yasmin and the SOGP leadership for allowing us to partner with them and have this webinar and conversation around this uh, important topic, which actually haunts Pakistan specifically, being in the top ranking, placing at the highest levels for both maternal and infant mortality, unfortunately. So I will introduce myself. The format of today's webinar is that I will do an introduction. As the moderator, I am Dr. Zakiuddin Ahmed. I am the project director of Riphah Institute of Healthcare Improvement and Safety, an institute of Riphah International University, which is one of the leading universities in Pakistan, which has led the journey of medical education and now as well as patient safety in Pakistan. I will give a brief introduction of 10 minutes of the journey and a little bit about patient safety. And then I will ask our keynote speaker of the day, Professor Dr. Paul Barish. He will introduce himself also, but he's a professor of Wayne State University in the US, and he's also a visiting professor and a faculty at Riphah Institute of Healthcare Improvement and Safety, and has been with us from the day one when we started this journey. Then we will have Professor Dr. Halima Yasmin, who will actually talk about very specific aspect of patient safety and maternal safety and newborn safety. So we are really grateful to the society and as well as Dr. Halima for her visionary leadership. As soon as I spoke to her about this, she said, yes, we should do it. So I will start my presentation and I will share it. Okay. I have given my introduction. I'm the director of Riphah Institute of Healthcare Improvement and Safety, and I'm also the chairman of the International Conference on Patient Safety, which I'm going to talk about a little bit, and the president of Healthcare Quality and Safety Association of Pakistan. And we are celebrating the WHO World Patient Safety Day with the theme of safe maternal and newborn care. This is the first slide which I have prepared for the audience. And it gives you a very short summary of when and how did we start. So way back in 2004, when quality was not called patient safety, it was just mentioned as healthcare quality, we organized the first international conference in 2004 in Pakistan. And I just want to share something about it. We had 7 speakers, including an international speaker who's a signatory of the CPHQ certificate. We invited her from Canada, and we had leaders of quality from Pakistan, all over Pakistan, with 7 brilliant speakers. At that time in 2004, we only had around 10 or 11 people in the audience in that big conference which we wanted to organize. So that's how we started the journey against all the odds, within an environment where no one knew or no one gave importance to quality in healthcare. So it was a very difficult journey, but alhamdulillah, some of us kept on working on it, and you can see that in 2021, now we are in a position to start our patient safety journal, which again will be the first in the region. So it has been a long 17 years of journey, but a very fruitful one, I must say. This is when we, started working on quality, and I wanted to mention Mr. Nadeem Mustafa Khan, who had been the CEO and Director General of Aga Khan University Hospital, and we consider him as the founder of quality healthcare in the country. He actually led this concept of quality, and people like us, we were inspired by him, and then we continued the journey. Once he kind of stopped working in it, we still ask him, and he still, honors and graces our conferences. So thank you very much, Nadeem Mustafa Khan, for making us work in this important area. Alhamdulillah, in 2016, Riphah International University, started this initiative, and it was under the visionary leadership of the Chancellor of Riphah University, Mr. Hassan Mohammad Khan, who's the son of the founder of the university, General Zulfikar Khan, who's the founder of Armed Forces Institute of Cardiology as well, and a very, very respected cardiologist in the Pakistan Army. Hassan Mohammad Khan, concurred with the vision, and he allowed us to establish this institute, which became the first in the region, not only in Pakistan. And ever since, Alhamdulillah, we have been working together in different areas, as you can see here. And as I mentioned, Professor Dr. Paul Barish has been with us from the day one. We started simultaneously, we started an international conference on patient safety. And as you very well know, that when you start a journey, it is important that you gather the stakeholders and create a momentum. So this is the first event in Pakistan where we gathered all the stakeholders from both within the country and some international speakers from abroad, and created this momentum, which we kept every year. So this was the first conference in Islamabad. Then we brought the concept to Karachi, where Aga Khan University Hospital generously and with open heart offered to host our conference. And this was perhaps the first time when Aga Khan University opened up its doors in such a generous manner that they hosted a conference of another university. So it was a very good example of collaboration and partnership. This became a very successful second conference. And then we took the conference to Lahore, where the CMH and Pakistan Armed Forces hosted our conference. Again, it was very successful in helping achieve our objectives. And then we took the conference to Rawalpindi, and as you can see on the right top corner, that we had more than 1,000 people attend the inaugural session of this conference, which had all the stakeholders. So you can see on the top, we had nurses, pharmacists, and leaders in healthcare from Pakistan, and a very, very strong faculty from abroad. This is when Imperial College formally partnered with us, and we conducted a few workshops certified by Imperial College and another institution from Switzerland. The institute has been engaged in very regularly engaged in capacity building workshops for the last, I would say, 6 years. Alhamdulillah, we have conducted numerous workshops, trained, hundreds or thousands of healthcare professionals. We very actively have been working with WHO and Ministry of Health as their partners in executing a specific program, which I will mention in the next slide. This is where we host the WHO delegation, and when we took them across the country to meet all the stakeholders. This is the Patient Safety Friendly Hospital Initiative of WHO, which we were partners in execution in Pakistan as an institute, and we conducted multiple workshops and trained numerous professionals in private as well as government hospitals. We have been leading the HQSAP and conducting quality and patient safety meetups at different institutions. We have a very strong partnership with the National Institutes of Health. My presentation has been visible to everyone. Yes?
Yes, Dr. Zaki, we could see
Okay,
it.
thank you. Okay, thank you very much. So as I said, we have been very strong in a strong partnership with the National Institutes of Health under the visionary leadership of General Amir Ikram, who's the executive director. And now, he and I work very closely and the institutes in this journey in Pakistan. Again, as I said, that we work with the Ministry of Health, and the Minister of Health at that time, a few years back, Dr. Zafar Mirza, who was from WHO, he gave us a few targets, and Alhamdulillah, we have achieved those targets. Another strategy of promoting and creating awareness of patient safety was that we started establishing centers of patient safety in the universities of Pakistan, kind of an incubating these small centers, so that helping the universities so that they can then convert those centers into institutes of their own. So we have already partnered with two of the major universities, Dow University of Health Sciences and Jinnah Sindh Medical University in Karachi, and a few medical colleges in other cities as well. About the international collaboration, this is there are a few slides where I wanted to show that we work with pretty much all the countries in the region. So this is a picture of signing an MOU with Saudi Patient Safety. We were part of the 4th Global Patient Safety Conference, which was a huge event where around 55 ministers of health from all over the world attended this event, and Riphah Institute was part of it as well. Jordan has been active in patient safety and quality healthcare, and we have a partnership with them. We are very active in Turkey. We even organized a few conferences jointly in that with local institutes. One of our flagship partnerships has been with Imperial College London, which has been supporting us in our conferences and our workshops. Riphah brought Pakistan on the map of the leading health system network, and now Pakistan is on that network, as you can see. Our recent collaboration has been with the British Medical Journal. We have also collaborated with University of Edinburgh, and we received a grant to work on patient safety in Pakistan through the Riphah project. And our recent collaboration has been with BMJ, British Medical Journal, and very soon, inshallah, you'll be hearing good news from us, all of those who are interested in patient safety in Pakistan, that we will be bringing out, inshallah, in addition with them, with British Medical Journal. This again is a very recent collaboration with Rotary Pakistan, Rotary, and we conducted a webinar a few days back, where Rotary, which is the largest organization in the world, which spends billions of dollars in healthcare, funding different countries, they are now focusing in patient safety, and they chose 2 institutes to showcase to more than 100 country representatives in the webinar. And Riphah and Pakistan was one of those few. The other was Saudi Patient Safety Center, Saudi Arabia. So I think that's we are very proud of bringing Pakistan on the map of serious conversations. That was the background of our journey, and I'll just share a few slides. I know that Paul and Dr. Halima will actually talk about the academic side, but just to create an environment. WHO says that 1 out of 10 patients are harmed while in a hospital. In the MENA region, WHO says it's around 20%, and I'm afraid that in Pakistan and our part of the world, it may be around 30 to 40%, which is huge. The third leading cause of death in the US has become patient safety or preventive medical errors. Just wanted to mention this first document, which is called To Err is Human. That's when the journey of patient safety started. I'm sure Paul will talk about more on this. And, people started thinking that, okay, this is also a problem. And this is one of my favorite slides. I hope Paul is not using it today. And if he is, then I apologize to him. But this is a way of presenting or convincing people that patient safety or preventable medical errors are a problem. You cannot ignore. If you cannot ignore 4 jumbo jets going down every week, you simply cannot ignore that. then why are we ignoring that more patients are dying than collectively 4 jumbo jets going down? So this is something we need to think about. I always thought that it's not fair to talk about patient safety and not talk about the individuals or non-healthcare professionals who actually have been driving this journey. So these are the people who were unfortunate to lose their loved ones because of preventable medical errors, but they did not stop and they started movements. And these are some of the people, not all, who started the movement, and they contributed in patient safety and where we are today. So I wanted to acknowledge them and their role. And lastly, the second document, which then talked about kind of a solution to the patient safety problem. And this document, which is called Crossing the Quality Chasm, for the first time as a fundamental in healthcare, talks about patient-centric healthcare. And I want my audience to please go through this slide and just think about this. As physicians or healthcare professionals, are we treating our patients as we see in this slide? Are we respecting them? Are we considering them as our partners? Are we valuing their preferences and needs? So this is something we need to think about, and one of the major take home of my presentation today. So as I said, BMJ has been leading this journey, and if you just look at this statement, let the patient revolution begin. So BMJ is very, very clear, very strong, very assertive that now we have to bring patients at the center. We have to make patients as our partners. That is the way we will improve the patient safety issue. And I'm sure that Paul will talk about the system side. He's a specialist in that area. So my last slide is that what is the way forward? I always believe Riphah Institute of Healthcare Improvement and Safety has always believed and practiced that we want to be an open organization, and we want to partner and collaborate with all stakeholders in healthcare. So Malcolm X put it very, in a brilliant way: when I is replaced with we, even illness becomes wellness. So together, let's become we, rather than working in our islands of excellences, and become we. Together, let's address this problem, and together, let's solve this problem, inshallah. So with that, I will end my short introductory presentation, and then I will request our keynote speaker from the US, Professor Dr. Paul Barish, to introduce himself and talk about this important topic. Dr. Paul, you can start sharing. I will just okay, so I'm giving you the rights to share, please.
Thank you, Zulfi. Thank you, Zaki. Hello, everybody. Good to be with you today. Zaki and I have talked about these topics so many times that one wonders, is it just about talking more about this topic, or how can we truly make a difference? And in this wonderful and important week of patient safety, I think it's important to reflect back on why it's so difficult to get people to change their behavior, and how can we make a difference in that journey. So I'm going to share my slides, and hopefully if somebody can give me an indication if you can see my slides.
Yes, we can, Paul.
Perfect.
If you can put them on the slide show mode, please. Yes, got it. Thank you.
So this is some of my background. I've been involved in this work for about 20 years, both as a patient who was harmed, as a father who had a child who was harmed, as a child of my father who was harmed, and as somebody who has spent about 25 years working very closely with clinicians and managers to think differently about these issues of both the science of safety, but perhaps more importantly, the implementation of safety, and why is it so difficult to get things to change. So I want to share with you today a few thoughts, starting with the data. So these are the most important documents that you should be familiar with. They're written in very accessible data. On the left is the OECD report on universal healthcare coverage and the implications of not having coverage on quality. In the middle is the National Academy of Science, and on the right is the Lancet Commission. And all three of them point to a picture of what Zaki highlighted, which is excessive harm, both in developing as well as developed countries, with certain high-risk populations, particularly high-risk populations such as neonatal and maternal, pervasive human factors and systems problems, pervasive cultures of fear and shame and blame, and a lack of safety management systems. And while many people are trying and lots is going on, it's clear that the culture of care has only changed, perhaps at the margins, which is really tragic given how much good work has gone on. So I thought I'd start with this. This is the most recent overview of C-sections. And as you can see here around the world, the number of C-section rates continues to go up. And this is private and public. When you just look at the private, and it looks like I'm frozen. Can you hear me? Okay, good. Can you hear me?
Yes, we can hear you.
Perfect.
But
perfect.
the slide is not going forward.
Can you see this slide with the
Yes,
international? Yeah, thanks.
Yeah, we can. Thank you.
And so when you pull out the private data from certain countries, for example, Latin America, which is up on top in the brown, in Brazil, for example, the private cesarean section rate is about 84%, which is really outstandingly bad. The recommended WHO rates are about 10 to 12%. And of course, the more C-sections you do in general, the more it costs, the more there's complications, the more you need to deal with potential difficult airways. In short, this is a marker of how bad the problem is. However, when you look back in the last 100 years, you can see that the amount of maternal and child death per 100,000 delivery has dramatically gone down, starting in the 1920s, moving into hospitals, antibiotics, blood transfusions, exceptional good anesthesia. All this has brought it down quite low. So on average, things have gotten much, much better. But this doesn't unfortunately tell the whole story. It does suggest that science and innovation has gotten us very far. The problem now is that we're not implementing what we know. So this is not about new science. We don't need new basic science around neonatal and maternal care. We know more than enough to protect perhaps 95% of the mothers and babies that die around delivery. When you look at the map of maternal mortality worldwide, it is tragic when you look at the differences between high and middle income countries and low income countries. And sadly, Africa and Asia and Pakistan, unfortunately, is at the top of those levels, which is really tragic. I think it's the #1 country now for neonatal death and nearly the top 5 in maternal peri-delivery death. In my mind, this is a national crisis, and it's not just a crisis of health, it's a strategic crisis, obviously, because what it does is, in addition to the terrible harm to the mothers, babies, and families, it's an existential crisis for the country because it saps trust, it saps resources, and ultimately undermines the trust and the support of the people and governments. Just to be clear, this isn't just in those countries. Here you can see mortality that has risen, risen in the last several years. And you can see Mexico, Chile, but also the US where mortality has risen. So for the first time in the last 40 years in the US, mortality rates have gone up. And you can see here that mortality rates in the US compared to developing countries where the numbers have gotten better, you can see in the US, it's actually gone up, which is really, really staggering. And there's a whole range of reasons why that is the case. It's important to realize this is not about money, although money is important. There are many other reasons why this continues to happen, will continue to happen. It is not a resource problem. Although resources are key, it is not a resource problem. And I'm glad to send afterwards a whole series of articles that shows that this is not about more money per se. It's about implementing what we know. It's about holding people to account. And it's about having a safety management system in the hospital, the region, and the country. So when we think about, there have been declines, and it's clear that some people, even in low-income country, are doing it really, really well. For example, Cuba is a country that constantly gets risen. Russia is another country. There's a variety of countries that are considered to be lower middle income, and yet they are able to marshal the resources to achieve remarkable outcomes. So I want to invite you to think about the quadruple aim. And this is a measure of sorts. It's a composite measure, which made up of 4 separate elements. Number 1 is patient safety, of course, at the center. Number 2, of course, is the experience, and not just safety, but what is the service? What is the environment? Related to that is the health of the population. So can you go home? Do you have good 30-day outcomes post-hospital, readmission rates and support on the journey to the home? The next, of course, is the cost. How much does it cost to do it so that you're able to sustain the system? And finally, and most importantly, what was added in the last several years is health worker safety. And while today the talk is not about COVID, let's not forget that according to Amnesty International, over 17,000 doctors and nurses have died during COVID from all countries almost around the world, including close to 3,000 in the US. Staggering numbers by any regard. And this, of course, means lots of people burning out, leaving, retiring, as well as refusing to be forward facing towards patients because of this. The second concept I want to introduce is what we call a human factors model or a social technical model. So when we think about a system like perinatal safety or maternal safety, I want to draw your attention to the right to this model called the SEPS model that was designed first by Pascal Carillon from Wisconsin. So if you look at the outcomes on the right, safety for patients, safety for the providers, safety for the system, you can see that what mediates the outcomes and the work system are the processes. And I think that is where we need to focus on for the next decade. The physical environment, the hospital design, the cognitive environment, what's happening around the providers, the support, the culture, the engagement, and of course, the behavioral support that they get. We know, for example, that when nurses are afraid to speak up, more patients die independent of how good the doctors are. We know, for example, that facilities by themselves contribute to infections, contribute to noise, contribute to slips, contribute to a whole variety of infections that are unique because of poor ventilation, poor sunlight, and poor nature exposure. On the left is a very important concept, which is the next one I want to share, and that is work as is versus work as imagined. Many times we don't really understand how hard and the challenges that nurses and physicians and birthing teams have to go through, midwives, because the work at the coalface, the work actually delivering the care can be very different than the work that's described by the managers or the work that's documented in the chart or the work that gets paid for. And that gap, again, is something that we're more and more appreciating is really quite important in order to deal with the complexities of lack of engagement, lack of trust, lack of truthful documentation, and lack of a culture of safety. If you do have questions, please put them in the chat box and we'll answer them afterwards. This is a very nice model which comes from UNICEF, which has been used in low-income countries and low and middle-income countries. And the idea is, how do we build a safety management system in these settings that's not just about collecting data, but it's learning from the data, it's doing proper M&Ms, it's understanding how the team works together, and it's looking at the proximal and distal causes. And clearly, a lot of good work that's gone on around this issue of maternal safety. And I'll be remiss if I don't mention Zulfi Bhutta, a good friend of Zaki and mine from Aga Khan, who's just been awarded a major award in North America because of his work on implementation of perinatal and maternal safety in Pakistan and Asia. And his work is really focused on not just physicians, but the physician extenders in Pakistan, the lady health workers, the non-physicians, non-nurses, who essentially are the only people that are seen by perhaps as many as 20 million Pakistanis. And so clearly hugely important for implementing care in rural settings where maternal mortality and perinatal mortality is quite high. So moving along now, if we think about the causes for maternal adverse events, we know that age, we know that weight, and we know that C-section. And so, for example, here is the US. We can see that Texas moms are dying, and you can see here that, again, that tends to correlate with weight and age. The older the women are, the more likely they are to get in trouble, and the more likely they are to refuse to get adequate care. Equally, you can see here about cesarean section rates and birth weights. And again, you can see a related correlation that's connecting the two. When we talk about the causes that get moms in trouble, so you can see some of the causes here, hemorrhage and CVAs and infections, et cetera, but very clear that hemorrhage and cardiomyopathy are the number 1 and 2 reasons, acute cardiomyopathy caused by a massive load on the right heart, which dramatically changes the physiology of the mom who prior to pregnancy, while overweight but was healthy and was not impaired. Suddenly they're pregnant, they can't walk upstairs without getting short of breath, they can't do much work at home, and suddenly they have massive dilatation of their ventricle, insufficiency, and ultimately cardiac failure and sometimes a cardiac collapse. So the other important thing to think about is, and this is a very important concept that's introduced by the WHO and others, and this is the 3 delay model. So if you think about the key causes that cause these problems, we tend to categorize them according to 3 main reasons. Number 1, decisions by the mother or family to not seek care for a variety of reasons, from medical, financial, or religious reasons. Number 2, identifying the problem but delays in getting to the organization. And number 3, getting to the organization, but not having adequate care, not having proper anesthesia, proper transfusions, proper central line management if they need to get rapid transfusion, inability to do a quick C-section if you have to get in and get the baby out. And of course, the factors that below that, and you can see that the solutions are very different for these 3 delays. And so it really requires a multi-pronged effort to deal with these 3 different delays, and most importantly, a political commitment. I'd love to see people, managers, executives, politicians, both in Pakistan and others, identify perinatal safety and maternal safety as the number 1 health problem. It's not that there are not other problems, but there's not always the political commitment, which then trickles down and doesn't get enough support later on. So, C-sections seem to have gotten better and better. And yet when we look at C-sections, for example, this is the US, and you can see that C-sections have actually continued to increase, as I showed you earlier. Remarkably, in the US, you can see particularly in the US South, which is well known for poverty, well known for poor medical care, well known for abstinence from a whole range of public health, including, by the way, very, very poor vaccination rates. And they have the highest COVID rates in the US. So going back to this lovely paper from the Lancet, the best way to support moms and bubs is by connecting the mother prior to pregnancy or during pregnancy to a healthcare system, either a primary, secondary, and tertiary, and making sure that connection is based on trust, is based on support, meeting the mother and family where they are, not embarrassing them because they might not be able to read or they might not be able to understand, but supporting their lifelong development so that they're able to grow a family and they're able to nurture their children and family. It's clear, for example, that a previous vaginal is the best way to have a safe delivery, which is very interesting. A previous C-section is a huge problem. A previous vaginal is the best way to stay safe. So another important aspect. In fact, after C-section, there's no reason not to try a vaginal delivery, which is clear, but somehow not always respected. Here you see, for example, different mortalities based on placental pathology, uterine atony or rupture. Again, massive increase of mortality, particularly in poor settings, so 4 to 5-fold worse. So this brings us to another quick overview of the team model. So this is a model that we've worked on for about 15 years called Team Steps. It's freely available at the website for Team Steps. And it's all based on this model of trust, communication, and shared mental model. We've done this in maternal health systems in a variety of countries. We've been able to reduce communication failures, adverse events by about 35%, and ultimately reduce miscommunication, near misses, and improving outcome. And it's all based on teaching teams around perinatal care how to be a team leader, how to be a follower, how to support each other, how to talk to each other with respect, and ultimately, how does this translate? And so the knowledge, skills, and attitudes, highly measurable. And again, if you send me an email, I can send you some of these papers to follow through on them. Another concept before I wrap up here is this issue of high reliability organizational models. This is the most cutting edge model around the world. And what it speaks to is the power of culture. So we can do all the stuff that we need to do around outcomes, around accountability, around standardization. But if the culture is not about trust, if it's not about lack of fear, if it's not about the ability to speak up, you're not going to get to safety. Here, John Cotter, in a very lovely book, easy to read, talks about this idea of how to support readiness for change. And that means if we want to get perinatal teams and the managers around those teams to change, it has to be an urgent problem. There has to be a burning platform. We have to focus on this solely because it's that important. So let's wrap up here with innovations. This is a very powerful book about how do we get change to happen when people are resistant. This is across 40 different industries. And what Evert Rogers suggests is that if you're going to get things to change, here Mary Dixon Wood shows, first of all, it's not about the intervention. It's all about the engagement and the support of the providers, the nurses, the midwives, the lady health workers, of the physicians. Those are the reasons that lead people to change. If they don't believe in you or they don't trust the change process, they're not going to do it. This is a book that we recently published, which has a lot of material on this idea of how do we improve the perinatal teams and how do we implement these ideas. This is not basic science. This is all implementation, secondary and tertiary science about how do we get people to do it using a PDSA quality improvement model. Again, effective innovations, we know about this. Effective implementation, which is all about governance and leadership, and the context in which these perinatal care, that leads to remarkable improvements in child safety, neonatal safety, and maternal safety. So we know that maternal mortality is rising worldwide remarkably. Cesarean section is a serious problem that clearly is a political and financial issue. We know that if we're going to get these things to go down, we have to focus on C-sections, but more importantly, we have to focus on creating a safety management system in obstetrics and around perinatal care, because otherwise we're not going to get much change around this space. So this is my email and my WhatsApp. There's a lot more to talk about this, but Zaki asked me to speak shortly. I'm delighted to answer questions about this, and I look forward to the conversation about how do we improve the perinatal and maternal safety and quality in Pakistan. Thank you.
Thank you very much, Paul. As always, it was very, very precise, very informative, and I'm sure that our participants, as well as all the people who will actually watch the video and the recording later on, will definitely contact you, and they will have a lot of questions. And I'm sure they've learned from this. And we will come back to you after Dr. Halima, presents her presentation, and then we will have a kind of an interactive discussion between you and Dr. Halima. As this is being recorded, so it will be useful for people who join us later on. So now I would request Professor Dr. Halima Yasmin. Again, I want to thank her because of her proactive approach. As I said earlier, as soon as I talked to her, she was like, yes, and I'm sure that she got the approval from the leadership immediately. Dr. Razia Korejo, again, we respect her all. So thank you to you, to Dr. Razia, and other leaders of SOGP for partnering with us. And please go ahead, start sharing your presentation. Dr. Halima.
Thank you, Dr. Zaki and the organizers for today's session. I'm really grateful, and I'm pleased to share the screen with a wonderful speaker like Professor Paul and yourself. So I would be basically talking more on the maternal aspect, specific aspects of maternal care. So if we talk about what is safety of care in maternity and neonatal care, just availability and utilization of health services, as already shown by Professor Paul, is not sufficient always to guarantee better health outcomes. Unsafe care is a global challenge worldwide. Maternal care is a special type of healthcare field where changes can evolve very rapidly. We all, as health professionals in obstetrics, know this. I'm unable to move my slide. So if we talk
Yeah,
about
it's
the
moving.
components, yes. If we talk about the components of safe maternal care, we can talk about different components like safe medication and injection practices, safe surgery and safe delivery, appropriate monitoring, effective use of vaccination to prevent the maternal health problems, prevention of infections, which can be hospital-acquired, and special infections in pregnancy. Trained providers is a very, very important component. BPH prevention and management, which is the leading cause of maternal death worldwide and highly preventable if we follow the safe patient safety culture. Safe contraceptive and abortion services, and respectful maternity care. So talking about them one by one, if we talk about safe medications and injections, we do come across a lot of practices when we have to give an injection to a patient in obstetric practice. And a safe injection or phlebotomy is a procedure or intravenous device insertion where we do not harm the recipient, which is the patient. It does not expose the provider to any avoidable risk of sharp injuries, and it does not result in any waste that is dangerous for other people. So if we talk about the medication safety in obstetrics, it's again the 5 R's, which is the right drug, right route, right time, right dose, and right patient. If we follow all these steps, we definitely would be able to deliver safe care to our obstetric population. We do a lot of surgeries nowadays, as already mentioned, the cesarean section rate, the gynecological surgeries, the other obstetric procedures are rising. But there are evidence-based, research-based tools available, which one can use in the practices. We conducted a research in our own institute among all the units, and it was very striking to know that a lot of surgical units were not using this tool. The surgical safety checklist, which is a time-tested, evidence-based, research-based tool. And if we utilize it at all the obstetric facilities, we definitely can bring down the patient events. Similarly, there is a safe childbirth checklist. This ensures ample preparedness and a lot of safety measures to be dealt with before we actually deliver the child, during delivery, and even post-delivery. Similarly, if we talk about any patient who has delivered, who has to deliver, who has to undergo a cesarean section, we should not underestimate the value of appropriate monitoring. A lot of problems just happen because we don't pick up the problems in time. And so utilizing tools like modified early obstetric warning scoring systems, MEOS charts, which are color coded, especially for systems like ours, where nurses and midwives can also see that the monitoring is now entering into the orange or the red zone, and they can report to the seniors, and the problem can be picked up. And the underlying principles for this is that patients who develop serious illness will usually display some abnormalities in simple physiological parameters. So appropriate and real fair monitoring is of paramount importance. Similarly, if we talk about vaccination, there are so many vaccinations available, and we should not bring in the myths of anti-vaccination campaigns to our care. We should give the best care to our women. There are so many vaccinations which are available. Most of them are live attenuated or killed viri or bacteria, which can prevent so many infections which can harm these ladies. Any infection, if they occur during pregnancy, put the woman at a higher risk of death and morbidity. We have Boostrix, which is combined Tdap, hepatitis B, hepatitis E. Special mention about hepatitis E in Pakistani scenario. We lose so many young women due to acute hepatitis because we know that hepatitis E in pregnancy is far more detrimental. And hepatitis E vaccination is now available by local manufacturers, and we should promote these. Influenza, meningococcal, poliovirus, rabies, typhoid, anthrax, yellow fever, and now COVID-19. We must all very, very proactively ask our women to get themselves vaccinated, not only to save themselves, but their unborn babies. So if we talk about general infections and hospital-acquired infections, we can see that it goes a lot of ways, right from hand hygiene, safe personal protective barriers, environmental hygiene, screening and cohorting patients, keeping the infective patients in separate care area, surveillance, antibiotic stewardship, which is a very, very important thing to be considered in our patient care, especially in obstetrics. We just give one dose and we forget. We even don't ask for the compliance from our ladies, whether they are taking medication properly or not. Has she understood what dosage and for how many days has she has to take that medication? And again, at the core of everything, the culture of safety. Hospital-acquired infections add to the functional disability and emotional stress, not only of the patients, but the care providers. And this might lead to disabling conditions. We have all witnessed such infections in our patients. And they reduce not only the quality of life, but in our setup, even they can be life-threatening. And organizational and behavior change underpins the success of infection control interventions. All hospitals should have infection control committees. Obstetrics units should have infection control committees. And this is a global targeted initiative. We should raise awareness of the need for improved infection control measures during childbirth. Having trained providers of all cadres, talking about obstetricians, anesthesia specialists, nurses, midwives, ancillary staff like lab technicians, operation theater technicians, not only proper training, but high quality, dedicated training, and empowering those trained people to develop their leadership skills so that they come up as a focused professional. And I would again mention over here, the role of interprofessional teams, the collaborative care, can never be underestimated. Evidence has suggested world over that outcomes can be improved by skilled birth attendants, but just the presence of skilled birth attendant in recent years has shown, especially in Southeast Asia, has not been very successful in reducing maternal and newborn health indicators. So we need to develop the quality indicators as well, whether these skilled providers are following those quality indicators or not. And if the system is supporting them to practice those safety measures in a proper way or not. If we talk about PPH, which is a major killer, and it is so much preventable, we must follow the proper evidence-based guidelines. We must prevent with active management of third stage of labor by preventing anemia by high quality antenatal care, finding out the risk factors for PPH in deliveries. But despite that, the PPH can occur anytime. So offering a bundle approach of putting in all the evidence-based tools like aortic massage, aortic compression, uterine massage, uterine balloon tamponade, high quality uterotonic agents, and blood transfusion services. By all this, we can prevent deaths related to PPH. And if a patient has to undergo intervention, then a high quality surgical procedure like B-Lynch or compression suture or an obstetric hysterectomy or devascularization procedure. If we talk about safe contraception and abortion, if we prevent pregnancies, the pregnancy-related complications can also be prevented. So unplanned pregnancies can be prevented by proper contraceptive guidance. Similarly, sharp curettage should be abundant It should be prohibited. The practitioners and providers should train themselves in other safer practices like manual vacuum aspiration and medication abortion. Coming to another aspect, which is so damaging to the mental health of our patients, the respectful maternity care. The emphasis of creating awareness of care providers on the standards and categories of respectful maternity care is very, very important. It is an approach which is patient centered, and it is an individual based on principles of ethics and respects of human rights. Our women are poor women. They come from a varied background. They already have faced so many complications in the periphery. The only thing which they have left when they reach us to tertiary care hospital is their dignity. I request you all, please don't damage their dignity at that time by asking questions like judging them. Where have you been? Where have you been treated? Why didn't you reach the facility in time? It is not my and your job. We have not been into their boots. We don't know what suffering have they have faced. So we must follow all these 7 rights of respectful maternity care. And I'm going to present a poster in upcoming FIGO on this as well. I'll request my fellows to please see to that in the upcoming FIGO conference. So we must follow the respectful maternity care guidelines, and all these 7 rights of a patient should be respected by us. So I would like to conclude that in addition to typical threats to patient safety, pregnancy, childbirth, and postpartum year presents a complex set of safety challenges, which we need to be more proactive about. It cannot be just alleviated by following a general guideline. OPS and neonatal care is a very special kind and complex care which can turn into complication at any time. So we should be involved to face these challenges of potential underusage, overusage, misdiagnosis, omission, and emotional harm to our patients. So we can focus on continuity of care before, during, and after childbirth, uniformity of services, equity of care to be delivered to all women if we want to achieve universal health coverage, and the sustainable development goals. Appropriate care based on the assessment of pregnancy related risks regarding to the case at hand. So one shirt can't fit anyone. We have to tailor make our management protocols to the needs of one woman, which might be different from the other. And a culture of collaborative care, a culture of patient safety, a culture of patient centered care, and a culture of partnership will definitely go a long way. Thank you very much, the Center for Patient Safety, for letting me speak on this, which is very close to my heart. Thank you.
Thank you, Dr. Halima. A brilliant presentation, I must say, mashallah. And I'm so glad that we had this webinar because we were having our share of challenges, and we were extremely committed in other pre-planned activities all around Pakistan. But I think your commitment and the interest, made sure that we kept planning, and finally we have, alhamdulillah, conducted this, and I'm so happy, and I've learned a lot from your presentation, Dr. Ima. Thank you very much for summarizing a few of the things which I have observed in your presentation as well. Is the mention of culture, is the mention of leadership. In a few slides, I see that people are now realizing that it's not enough to train our residents or even faculty and consultants on the clinical aspects. We have to focus on helping them to understand what leadership is about, and how important culture is. As I said before, Paul is an expert, and it's very close to his heart. Paul always talks, and I'm sure that he will end his today's talk with a few mentions of culture and leadership. So Riphah Institute of Health Improvement and Safety would love to collaborate with SOGP on patient safety, on developing a culture of safety, and on developing their members on leadership as well. I will now open the floor to Paul and Dr. Yasmin both. I would suggest that if Dr. Halima can ask a question if she has to Paul, and if Paul wants to talk to because we are not opening it up for the participants as such because of the scarcity of time. So over to you, Paul and Halima.
Thank you very much, Dr. Saki, for giving me this wonderful opportunity to talk to Dr. Paul. Dr. Paul, your work at Team Steps is commendable. I must congratulate your organization and Riphah Institute for having you with us today. May I ask you that you seem like having extensive knowledge, and the documents, the books, the literature you share with us today was really impressive. So if we talk about the Pakistani context, as you have been here multiple times, you know our shortcomings, you know the challenges, you know the level of commitment at our government and political level. What do you think could be the game changer for societies and organizations like SOGP and practitioners like me who want to inculcate this? How can we start? If we are really committed to it, how can we start to collaborate and bring a change, at least to some institutes?
It's great to meet you, Dr. Halima. I really enjoyed your talk. I think it starts by telling the truth. I think it starts by not having false targets. I think it starts by acknowledging that we could do better. I think it starts by not being nationalistic about it. I think it starts being very honest about the fact that this is an existential crisis for the state of Pakistan. I'm not exaggerating. If you think about, the lack of trust that flows from this, if you think about the corruption, the soft and hard that goes with this, it's so hard for people down the line to actually pay attention to the indicators, to pay attention to all the good work that you're doing. And so much stuff doesn't go very far because there are all these other forces. So I have a model, we call it the 4T model. It starts with truth telling, T, with transparency of data. So showing doctors and nurses and the people what the real data is. That helps build trust. Trust doesn't happen unless there's truth telling. Truth telling doesn't happen unless there's transparency. They're highly coupled with each other. Those 3 T's lead to the 4th T, which is teams. Teams on paper look great, but they don't actually engage with each other. They don't tell the truth to each other. They don't have each other's back. And ultimately, they're a group of people that fail to deliver. We see this in cricket sometimes. We see this in basketball. We see it all the time in medicine. And that means meaningful integrity of the teams who struggle around these issues. So that's what I would say is the most important thing. And having been to Pakistan probably 10 or 12 times and worked with clinicians and worked with Riphah and many other places, I'd say that that's probably the biggest obstacle, is that we have to stop the hagiography about how great we are. We have to talk about the challenges. We have to be honest, meeting people where their problems are. Because unfortunately, when people hear the good stuff, and there's a lot of good stuff, when they hear the good stuff, they think, oh, it's not so bad because, hey, it's also good. And the data, with all the problems that go with the data, suggests that there are serious and fundamental issues of truthfulness around reporting, timeliness of telling people what's wrong, and most importantly, supporting the frontline workers, giving them the resources, supporting their passion that they've committed to healthcare. So many healthcare providers have been harmed in Pakistan during COVID. That's going to have years of an impact, not just around COVID, but around perinatal care. And so again, let's talk about health workforce safety, the physical safety and the emotional safety and the implications for that. We're seeing in the US that there's a shortage of 30% of nurses. Simply put, nurses are not going back to their hospital care. That's what's happening. And that's having a huge ripple effect. And I'm sure it's going to happen in other parts of the world as well. And so regaining their trust is all about supporting them, listening to them. And let's be honest, we've not really respected healthcare workers. And maybe I'll end with the wonderful report from the G20 that Dr. Abdulillah Hawasawi helped co-chair, which speaks about this hidden pandemic. This was released in April this past year. And it talks about the patient harm, but also the staff harm, the physical harm, the emotional harm, the moral injury, and the fact that there's no joy left when they're struggling with a system that doesn't support them, either because they don't have workable wages, or because they don't have proper PPE, or because their bosses are belligerent and nasty to them, or because they can't tell the truth when they see, for example, a physician breaking the rules. They're afraid to say anything. These are the types of issues I think that would have the most mileage and probably cost the least amount as it relates to investment.
Thank you. So dedication, exactly, and really coming up, bringing it to our own selves, you think
Yes.
would be the game changer. Yes.
Absolutely.
Thank you.
Paul, do you want to ask anything to Dr. Halima, or any last few comments before we close the session?
Well, I think it's important. I alluded to that. I'm curious, Dr. Halima, how you think, and Zaki, COVID now into its 20th month is wreaking havoc on planning, on budgets, on access. There's a lot of innovation as well, but what are the lasting implications that you're seeing already around changes that COVID is influencing maternal and child care? And how do we prepare for this tsunami of waves, plural, that over the next several years, it's going to impact how we plan, how we roster, and how we support perinatal and maternal safety in Pakistan?
Dr. Zaki, would you like to respond to it first? Or should I?
Please go ahead. You are the expert, please.
Thank you. Dr. Pal, I think there's a negative and a positive side to your comment and question. I think there definitely is going to be a lot of stress related to this unknown enemy. The research is coming up very rapidly. The knowledge generation is going up. But are we still on it regarding the treatment, regarding the modes of genetic mutations coming up day by day, and the already overburdened health facilities almost succumbing to this virus and the related morbidities. Can we ask the participants to kindly mute? Sorry. So similarly, there's a positive thing. The vaccination has come up, and all the organizations have asked. I would like to particularly talk about pregnant women and their unborn babies. The organizations, the governments have shown their dedication now to propagate the vaccination drive. So I think that can be the safety like any other infectious disorder, and the culture of personal safety by proper standard preventing protocols, mask, hand hygiene, and all that, and adapting to the new lifestyle, adapting to new teaching and learning strategies, adapting to new strategies of research and healthcare. So without this, I think it would be a very fearful war. So I think we should definitely work on these steps and plan ahead, because a lot of countries, including my own and others, very developed countries, showed clearly that there wasn't any planning. It was coming up. So we usually lack planning for any big problem. So that, I think, can solve certain issues related to this. But there are minds like you working. You can come up with another model to fight this scenario.
Well, models are great. There's a very famous statistician, maybe Zaki we'll end with that. George Cox, all models are wrong and some are useful. Models can help us, but it's all about the local culture, the local willingness, the local leadership, and the spirit. And I'm always impressed with the incredible warmth and spirit and engagement of Pakistanis. And so how do we help pivot that and leverage that, Zaki, to help support this topic?
Sure. I think let's conclude us, and I'm sure that once this goes out, the recording goes out, a lot of people will benefit from this. And it's not only the conversation or the information which is important. I think the opportunity to collaborate, the opportunity of two organizations coming together, I think that's a very, very important opportunity. And I would like to, you know, close with this commitment from the Riphah Institute of Healthcare Improvement and the Riphah University, that as we have partnered and collaborated and worked with so many other institutes, organizations, associations in the last 6-7 years, we stand committed. This is, you know, a new partnership for us with the SOGP under your leadership. We see that there is a potential and a need for a lot of capacity building, I would say. So I would just summarize these areas into say 4 areas that Riphah Institute can help SOGP in developing, you know, these four areas. One is teamwork through team steps, and Paul is one of the co-authors of this framework, which has been, you know, has shown that it brings down morbidity and mortality. Leadership, culture, and communication. We know that around 70 to 80% of the preventable medical errors or harms have some kind of an association with communication or lack of communication or miscommunication. So we are now emphasizing much more on communication as we used to before. Obviously, culture, leadership, and teamwork has been with us. So, Rihis, wish to partner with SOGP. We can have a conversation, offline conversation, how the institute can assist SOGP as a national organization in building the capacity, in creating more awareness, and creating knowledge together. As I mentioned that we are, inshallah, bringing out the first patient safety journal of this region. And that is another area where we would like SOGP to help us, because you have been in this space for a very long time, much before. This is something new for us. We have taken this initiative. It's a major undertaking for us, and we need, you know, help from as many experts as possible. So that's something which we would like you to help us with. And as I mentioned that, you know, a major achievement for us has taken place, that Riphah Institute of Healthcare Improvement and Safety is partnering with BMJ in bringing out a special Pakistan edition on patient safety. So we would like to invite SOGP in that as well.
Thank you very much for offering this, Dr. Zaki, and for your commitment to the cause. As you would not feel SOGP behind on all these commitments, and we would love to join hands together with all organizations and collaborate in this regard. And this definitely will bring in some change in Pakistani women and children health. Thank you very much.
Inshallah. So with that, I end. I need to thank especially Paul, because you can appreciate that it's after midnight. What time it is? Is it exactly, Paul, at your end?
It's 1:38 in the morning.
Yeah. Although your background does not reflect that, but you know, we all need to appreciate and acknowledge and sincerely thank Paul for his commitment in helping Pakistan by, you know, staying up so late. You know, I was a little shy in asking him to present at this late hour, but I was confident that he would always say yes. So, Paul, thank you very much again. Sincere thanks to you for helping us understand and helping us in our journey. I want to thank Dr. Halima. I want to thank Dr. Razia Kurejo and all friends in SOGP who have confidence in us, who have supported us, and the participants who took our time on Sunday. And inshallah, this recording will be available on our YouTube channel, and then the link will be shared with SOGP and other partners as well. I wish to thank my team at Rihis, you know, who you cannot see, but they have been working from the, you know, behind the scenes, as we say. So I thank all of them. Thank you very much, and hope that we can reduce the preventable medical errors, inshallah, in Pakistan together. Assalamu alaikum. Thank you very much.
Thank you. Good night, everybody.